Recently, the Pitt series has created quite a buzz. A couple of my patients and colleagues mentioned it to me, so I thought, why not check it out together? I heard there is an episode about the stroke, and since I actually started my career in the stroke department and I worked there for 5 years, this feels personal. Let's see how accurate it really is, and I'll post to add some comments along the way.
Ready to intubate. Push ketamine, then rock.
Okay, here's code stroke.
Okay, I will be right back. Jane Doe. Looks like she's in her 20s.
And here is the patient.
Right-sided hemorrhagic and facial droop.
Okay, let's pause here. Here they mention aphasia. That's when a person loses the ability to speak or understand language. Not because of their mouth or tongue, but because their brain language areas are damaged. Then right-sided hemiparesis, which simply means weakens on the right side of the body. And facial droop is when one side of the face sags because the muscles aren't working properly. These three things together is a classic stroke presentation.
Nod your head if you understand.
Receptive and expressive aphasia.
No motor strength in the right arm.
Open your mouth. Gag reflex present.
Which is good.
Left motor intact.
BP is 150/88.
Where should we go?
AQ check is 73.
Straight to radiology. CT brain without contrast. Perfusion scan. CT angio head and neck.
Her blood pressure is 150/88. A bit high, but for stroke patients that's actually common. The brain is often pushes the pressure up to maintain blood flow. And they check her sugar, AQ check 73. That's important because low or high blood sugar can mimic stroke symptoms. So doctors always rule that out first. Then he said straight to the radiology. Why? Because the fastest way to know what type of stroke you're dealing with is imaging. First, CT brain without contrast. That rules out bleeding. Then a perfusion scan that shows which brain areas are still salvageable. And CT angiography, that's to check the head and neck arteries for blockades. All three together give a complete picture. Is it bleeding? Is it a clot? Where it is? And how much brain we can actually save.
Didn't get a name on her?
We looked, couldn't find a wallet or an ID, but we had to jam out of there because it was a co-stroke. Who called 911? Well, apparently our Jane Doe is a professional gamer. She was a no-show for some big tournament, so her teammate in Dubai calls another teammate in Houston who called
Dubai
911
people
here.
Okay, let's pause here. Code stroke, this is the hospital's emergency alarm for suspected stroke patients. Everyone drops what they're doing because in stroke every single minute counts. And notice they call her Jane Doe. That's the name used when an unknown patient comes in without ID. I remember my time working in the emergency department. Nights like this weren't rare. You might get 7 to 8 stroke cases in one night without any sleep. And the crazy part, the night shift usually started right after your normal working day. So after the whole night, you'd go straight into the next day's shift. It's a huge experience, but honestly, it's brutal on the mind and body.
Who gets a stroke in their 20s?
That's what you get to figure out. Okay, come find me after
And this
the
is
scan
the good
results are
question.
back.
Who gets a stroke in their 20s? Most people think it's only older adults, but you'd be surprised. We see young patients more and more often. When I first started in medicine, if someone under 30 had a stroke, it was a big event. Everyone would gather for discussions and long meetings, but now it's sadly becoming more routine.
Intubating the burn patient.
Ma'am, can you close your eyes for me?
Checking the blink reflex.
Robbie, it's Amira. The endo CT came back. No bleed, but there's a carotid artery dissection left neck with a thrombus that threw a clot to the left middle cerebral artery.
Okay.
Okay.
Nice
got it.
iPads.
We'll wait. With no intracranial hemorrhage, she might be a TNK candidate.
But couldn't TNK cause a brain bleed and kill her?
TNK is still the best clot busting possibility.
Okay, so her scan came back, no bleeding, but she has a carotid artery dissection. That means the inner wall of the carotid artery in the neck tore and blood got inside the wall. That creates a flap and a clot which can shoot up to the brain and block arteries. It's one of the leading causes of stroke in young people. With no bleeding seen, she might be a TNK candidate. TNK or tenecteplase is a clot busting drug. It dissolves the clot from inside. But yes, it carries the risk of causing bleeding, which is why doctors carefully weigh the risks. The other option is thrombectomy, physically pulling the clots out with a catheter. Usually we go for that when the clot is large or drug alone might not be enough.
Shouldn't we do endovascular therapy? I mean, that's the safest option.
What do you call a Tyrannosaurus under stress?
What?
Nervous Rex.
Dr.
Alright.
K, meet Dr. Matha, one of our esteemed stroke neurologists.
That's jokes.
How's the patient?
NIH stroke scale of 27, no last known wall time.
Dr. Mehta, should we take her to
As
EVT?
usual.
Not yet. Take first spin in the MRI. Check for irreversible damage first. There's a diffusion flare mismatch. She's still in the window for thrombolytics.
And
Yep.
she still gets AVT. 2-for-1 special.
So, they mention NIH stroke scale. This is the scoring system from 0 to 42. It grades how severe the stroke is based on speech, movement, vision, etc. Here's the patient had 27 and it's very severe. Last known well is the last moment she was normal, because treatments only work in certain time windows. And diffusion flare mismatch on MRI means there are brain areas that looks damaged but aren't dead yet, still reversible if you restore blood flow quickly.
What type of person is best suited to work with an MRI machine?
A trained technician.
Someone with a magnetic personality.
I love this guy.
So next place on deck?
All set. She's 62 kilos. 0.25 per kilo is 15.5 milligrams.
That's how 10K is given, strictly
Diffusion flare
weight-based.
mismatch means she's less than 4 hours into it.
Getting TNK now.
Sounds great. Would you mind hanging down here for a bit? I could use your expertise on this.
Can't believe you had the nerve to ask.
Good one. Okay, keep me posted.
You know why they say laughter is the best medicine? Because it's true. Laughter releases
100% true.
Help relieve pain.
So what?
Dr. Mehta thinks that if a joke helps raise spirits and makes people feel better, then he's all for it. It's his special sauce.
Fair enough.
Do you have a special sauce?
I'm pretty data-driven, but I really like to talk to my patients about their lives. Makes them feel important.
And she's
Like
better.
what?
How are you feeling?
Are you trying to say okay?
Yes, the thrombolytics are working. Can you lift your right leg for me? That's okay.
Not yet.
Try moving it from side to side.
Can
Okay.
you tell us your name?
Type.
Oh, maybe you can type it out on the screen.
That's right.
Vera? Okay, what's your last name?
Malahi?
Well, hello, Vera Malahi.
Okay, good news, the thrombolytics are working. You can actually see her speech and movement improvement. That's one of the best feelings in medicine, watching someone come back right in front of your eyes.
I was getting ready to take her up when she developed angioedema and her stats dropped.
Okay.
A little bit of stridor.
Swollen lips, swollen tongue.
Vera, this is a side effect of the medication we gave you.
Sats are up with high flow.
She developed angioedema. That's sudden swelling of the lips, tongue and airway. Rare, but it can happen as side effect of clot-busting drugs. It's scary because it can block breathing.
It's anaphylaxis, get Robbie.
Angioedema is not always anaphylaxis.
I know, but it can progress to it and cause an obstruction.
If it's just angioedema, I can reverse the swelling fast with IV epi.
BP's 165/85.
Prep ketamine and rock for intubation.
Whoa, wait.
Yep,
Dr.
it sounds
Mohawk, you
good.
just said.
We're not intubating yet.
But she's gonna arrest.
What happened?
Angioedema with stridor. Respiratory's on their way. We should intubate, right? Are we intubating? Are we not intubating?
Not.
Strider is improving.
Is it getting easier to breathe?
Speech is coming back. 50 diphenhydramine, 125 solumedrol.
Do you think Dr. Mehta will want her intubated for the thrombectomy?
Not necessarily. If she can talk and move during the procedure, then they can monitor any changes in the neural exam.
Yeah.
Slow
That's important.
No-mo. Sorry, I think Dr. Mehta's rubbing off on me.
So, they give epinephrine. That's the same medication we use for anaphylaxis. That shrinks the swelling fast. And notice they delayed intubation. Why? Because if you can avoid putting a breathing tube in, it's safer for the patient. Luckily, the swelling resolved, her oxygen stayed stable, and her speech started to come back. And they mentioned doing thrombectomy without intubation, what's called awake thrombectomy. That's actually beneficial because if the patient is awake, doctor can monitor their neurological status in real time during the procedure. If something changes, they notice it instantly.
Angioedema responded to epi, diphenhydramine, and steroids.
Excellent.
Sounds good.
Thank you. You're very welcome.
Which neurotransmitter makes the best adhesive?
I don't know.
Glutamate.
Glutamate. All right.
All right.
Nicely done, Dr. King.
You know, it was really quick thinking back there. I'm really sorry if it seemed like I doubted you.
Is this the last scene with our patient?
Honestly, I surprised myself a bit.
Yeah? Or you trusted your gut?
Okay, actually it was more accurate than I expected. Pretty solid for a TV show. Maybe I should check out some of the other episodes too. If you'd like me to do that, drop a comment below. And here is one quick tip to remember for recognizing a stroke. Just think fast. Face drooping, arm weakness, speech difficulty, time to call emergency. Simple and life-saving. If you like this video, you can check out the next one right here. Thanks for watching and see you in the next one.